we've hit critical mass, so we can go ahead and get started, maximize our time spent in discussion with our lovely panelists here today. Thank you so much to everyone who's joining us. This event is called Evidence-Driven Solutions to the Opioid Epidemic, and we have three really great panelists who are representing different areas of trying to solve this really critical issue. So I'm excited to hear everything that they have to say about the topic. To briefly introduce myself as well, my name is Emily Schaefer. I am a volunteer with ESAL, or Engineers and Scientists Acting Locally. I will be moderating the discussion today. So just to give everyone an idea of what to expect for this event, I'm going to start off with a very brief introduction to ESAL to give everyone an understanding of our organization and what we do. We'll give each of our panelists a brief few minutes to introduce themselves a little bit more and their backgrounds. We'll go through some discussion questions to get us started from me, and then we'll save some time at the end for audience questions. So for everyone who's joining us today, I encourage you to use the Q&A feature on Zoom webinar to add in those questions. Feel free to add them throughout the event as you think of them. And you can also add some thoughts and comment on any other events that or other questions that are added, and we will get to those at the end. We really encourage a lot of audience participation as much as possible. So jumping into a brief introduction of ESAL. ESAL, or Engineers and Scientists Acting Locally, is a national nonprofit organization that's existing to encourage local civic engagement by people with science and engineering backgrounds. So we're really motivated by the core belief that democracy and the communities that it serves really benefit when everyone's involved, including our friends in science and engineering. And that in particular, people with the science and engineering background have this inquiry-based, evidence-driven, problem-solving skill set that really, really benefits the communities that they're a part of, and that you don't necessarily have to have subject matter expertise to always be participating in local civic engagement. And we're launched and led by many engineers and scientists who have experience in public policy. So what this means for us as members of ESAL, we have a lot of different responsibilities. One of those is just awareness raising. We use our national platform to highlight a lot of different efforts going on at the local and state level where scientists and engineers are getting involved, particularly through our blog and social media. We also do capacity building through events like these, as well as workshops and conference sessions. And then we also work to provide a lot of resources and support for scientists and engineers that do want to get involved. So if you leave this event today feeling very inspired, wanting to get involved, whether it's in this particular subject or just generally, I really encourage you to check out our website. We have a lot of different instructional content and a lot of different, we call playbooks, that give you the tools to participate yourself in local engagement. So everything from what does local government look like? How do I know that I'm talking to the right person with my concern or question? To how to submit public comments, or even how to run for public office. All of that can be found on our website. And if you'd like to get involved with ESAL even more beyond that, again, if you're feeling inspired, this is what we try to do, is connect with all of you in science and engineering. So I would encourage you to not only check out our website, but also check out opportunities to do things like write a blog post with us, volunteer with us, or if you're a member of a organization, student organization, company, university, scientific society, anything like that, and you think your organization would love a workshop on local engagement, we do that as well. So that's all I'll say about ESAL. Please check us out more if this is the first time you're hearing about us. But otherwise, I am going to stop sharing my screen and turn this over to our panelists. So panelists, I'm just going to go in the order that we have on our graphic and introduce each one of you. All right, so starting with Dr. Sullivan. Dr. Catherine or Katie Sullivan is a prescription drug epidemiologist for the Colorado Department of Public Health and Environment. She is the data steward for the Colorado Prescription Drug Monitoring Program, or PDMP, and its data. And so with university and other state partners, she uses PDMP data and other types of data to conduct research and surveillance, primarily relating to opioid use disorder and treatment.
Yes. Hello, Emily, do you want me to just give more of a broader background? Is that?
I'd love to hear a little bit more depth about your background.
Yeah, absolutely. As Emily said, I'm the prescription drug epidemiologist for the Colorado Department of Public Health and Environment. My background is mostly academia. My PhD was with Skaggs School of Pharmacy at the University of Colorado, where I studied pharmacoepidemiology. And so I'm really doing what I went to school for, which is pretty fun and pretty cool. After that, I did like a 1.5 years postdoc as well as a research scholar position. The postdoc was with the University of Colorado School of Medicine, where I studied machine learning and natural language processing and a lot of that more computery side of data analysis and some cool things like that. And then the research scholar position was at Stanford University, where I sort of went a little off track with what I normally study, but it was more about how the COVID pandemic affected international graduate student physicians, so individuals who were not from the United States who went to school here. And many of them work in primary care and that sort of specialty, and so that was sort of that project. And then I ended up here at CDPHE, working with the prescription drug monitoring program and working on the opioid use disorder, as well as treatment now, which is really cool. Me in a nutshell. Glad to be here.
Thank you so much for joining us. Next, we have Dr. Ed Bilski. Dr. Bilski earned his PhD in pharmacology and toxicology from the University of Arizona in 1996. He has had a distinguished academic career that includes an active research program focused on the neurobiology of opioids, pain, and substance use disorders. He has educated thousands of medical and graduate healthcare professional students and practitioners on opioids, pain management, and mental health related topics. Dr. Bilski is also very active in public education, outreach, and advocacy related to these topics through his affiliations with the Society for Neuroscience and other professional organizations. Today, he currently serves as the provost and the chief academic officer at Rocky Vista University and is a professor of neuroscience and pharmacology.
Thanks, Emily. I've got some slides together to kind of give you a little bit of the flavor of my background as both an academic and someone who has been an engaged citizen in arguably one of the biggest epidemics our country has ever faced. And so opioids in our community, a lot of this has been more recently focused on the impacts of the pandemic and how do we start to make progress, because it feels like we've been in a cycle for many, even decades, if not a century, fighting the concerns around opioids and charting a path forward that's going to be cost effective and doable, practical. So I kind of make the argument that I've been 50 plus years in the field. I'm only 56 years of age, but when I was a toddler, I was adventuresome. I would always seek out new opportunities, and one of those was a bottle of codeine cough syrup. I must have made a connection. When you had a cough, it was sweet. It obviously affected the central nervous system and was reinforcing. And I very vividly remember that cough syrup. It was yellow and it was quite sweet, syrupy. So this is before child safety caps. This was late 1960s. And I drank the whole bottle. And this is also before Narcan. So my parents rushed me to the emergency room. All they could say was, we're going to let him sleep it off. And about a day and a half later, I came out of this opiate intoxication. Fortunately, it wasn't fentanyl or a lethal dose. Why I use this to illustrate, I do come from an engineering background. I went to Rensselaer RPI. And, basically we have a problem with childhood safety. The engineers were able to come up with safety caps that made it much more difficult for children to open these potentially toxic medications. And this is now universal for anybody who's grown up since the 1970s. These have been in place and they have saved countless lives. The science of the opioids has really advanced too, and our understanding of receptors, opioid agonists like morphine, heroin, fentanyl, and the opioid antagonists that can reverse these effects, Narcan or naloxone and naltrexone, are relatively new inventions over the last 50 years. But the point I want to make is that when we have problems, taking that engineering mentality, understanding the system, and then applying some prototypes or hypothesis, doing further work, leading into practical solutions. These are two success stories that have occurred in the field, and I think there's many more that can be achieved through both the engagement of scientists and engineers. So my career has been understanding fundamentally how these opioid receptors work, and looking and developing animal models that can help advance drug development. But throughout that career, starting in graduate school, I was doing outreach, just educating K through 12 students on the dangers of opioids. Some of the work was clearly on prevention, but also it was trying to get people better informed on making adult decisions on things that impact their health. We wrap this into two populations: substance use disorders, people that struggle with these, and also with the chronic pain population. And instead of pointing fingers at each other, we needed to come together because both these populations are marginalized. There's huge stigmas associated with them. And those are barriers to getting effective treatment. Also, better communication and coordination of services that are currently available or should become available. So this led into the advocacy work that's been done at the local, federal, state, and federal levels. And it's been a lot of fun involving students and colleagues in that. I think the hard part for all of us is that we are frantically whacking the mole wherever it pops up and not getting to the underlying root causes that are contributing to the rise in the opioid epidemic. And that can get us frenzied and uncoordinated and throw resources at things. We need to take those bigger steps back and look at what are the root causes that contribute and try to intervene as early as possible. Prevention is always better than early intervention. And within this, some of the things that are lesser known about the opioids is that they play these subtle but significant roles in many aspects of behavior, not just the overt reward systems, the affect that can cause, that can lead to compulsive use, and the pain modulation, but many other things too: sensory processing, the sense of loneliness or the sense of belonging. And from an evolutionary biology standpoint, this is very strong. It's about 100 million years of vertebrate mammalian systems contain opioid receptors, and they played very important roles in these areas of social relationships and social behaviors. So we have to consider those things. I talk, to med students and others about sympathy and empathy. I think we all kind of have a general understanding of what those terms mean, but I'm going to argue that they're not sufficient. If we talk to this audience, I bet you if I had you all raise your hands, about 80% of you with the question, have you ever been stung by a bee? And we can understand, a bee sting hurts. We feel sorry for you. We feel some sympathy. We can understand if you come in with a cast or you show us an x-ray of a broken arm, and we might be able to have some empathy for that, understanding it's going to take some time for you to recover. It gets much more difficult as human beings to understand that coworker, that colleague, that friend, family member who's got chronic migraines or fibromyalgia. Some of these diseases and conditions that we don't fundamentally understand all aspects of it from a neuroscience standpoint. And we sometimes dismiss and marginalize these individuals. I think it's even more so with people with struggling with substance use disorders, in that we really, unless we've experienced it ourselves, we can't fully understand. You add in mental health, people with housing insecurity. There are not just stigmas and barriers, but we're afraid to engage these individuals. And that is a detriment to both community public health, to the individual, to the family, and the community. So I make the statement that compassion is even more important and more compelling. It's not just the empathy, but it's action to make a difference. So that's something that's guided my process of getting involved out of my comfort zones into working with vulnerable populations across the spectrum and trying to do something about that. And more importantly, getting others involved, channeling their individual career aspirations and their passions into something that can make a difference. I've done that successfully working with communities in Biddeford, Maine, an old mill town that was really run out of its luck. The jobs weren't there. There was high rates of alcoholism. The opioids started creeping in. And there was a lot of concerned community leaders, including the business community, that was needed to take action. And just there's a wealth of stories that came out of this. And Biddeford's reinvented itself and is really one of the best places to live in the country, and getting some recognition for that. Do we make an individual difference? It feels intimidating to talk to legislators. It was something I was not trained to do, and it just took some practice and some mentorship. But I worked with Senator Collins's office to work out a fundamental understanding of the interrelationship between the opioids, the pain population, and people with substance use disorders. And her staff that I worked to build a relationship with introduced aspects of legislation that modified the CARE Act that led to a better fundamental bill to help support. With the universities that we take part in, and the graduate students, the undergrads, the med students, we can go out and we can volunteer, take back programs, for example. We can do that in languages and cultures that may be different than our own, but with work, with people in the community, you can really make some effective programs. Talked about stigma. I've got many medical students who have suffered from substance use disorders that got into medical school, long-term recovery, and are now in residency and beyond. We've got to have those success stories, right? It's not you have some bad luck and you develop a substance use disorder. You might even be incarcerated like Matt did. You can turn your life around. We can't incarcerate our way out of this problem. We can't handle just the sheer number of people. So we've got med students talking about all of these deep, dark things that involve our brains, and shedding that stigma and getting people care early. Med students have gone to the state legislatures and introduced bills that have changed fundamentally some of the ways that we approach some of these issues. So I'm very proud at Rocky Vista. I'm joined, I think, by one of our colleagues here who's helped lead students to do these legislative changes on Narcan training and Narcan availability to make an impact on our communities. So I want to continue to do that. I can help in any way I can. This panel is just one part of that. So thank you. I look forward to the discussion.
Thank you so much for sharing, and thank you for being here. Right, last but not least, we have Ms. Susan Hertzfeld joining us today. Susan received her MA in sociology at UC Davis before working with the Child Death Review Team and Fetal and Infant Mortality Review Committees in Sacramento County, California. In 2017, she started with the Public Health Department at Dayton and Montgomery County in Ohio as an epidemiologist. She supports behavioral health data efforts in the county, including overdose and suicide surveillance, data reporting, fatality review. She works closely with local coalitions, including Montgomery County's Community Overdose Action Team, to share overdose and drug trends and inform overdose response efforts among the collaborative's multi-sector agencies. Welcome, Susan.
Thanks. I don't have slides, and you pretty much just said everything I was going to say. I will say that when I was studying sociology, I had a quantitative focus, and I'm wishing I would have done more training in qualitative, because in my work now I need it. What I do with Montgomery County, so I was in Sacramento, I was doing child fatality review, so I'd collect the data, I'd run the meetings, and I do data reporting. And we moved here to Ohio in 2017. And in 2017, Montgomery County in particular had a really high rate of overdoses. We had 100 per 100,000 in that year. So they created an extra epi position to support overdose data. And so I set up the fatality review, overdose fatality review. And a really exciting part of that is that we get interviews with next of kin. So that can kind of add to the information we get from our partners to learn more about the individuals and their history. So adding that qualitative element has really been helpful for us. I also work really closely with our coroner's office, so I'm able to get information from them daily on folks who passed away of overdose and suicide, so I can alert our community to trends pretty quickly as they happen. So I always brag about the partners in Montgomery County. They really are data hungry for data and data driven in their efforts, and I'm always getting requests for information and seeing how folks take it on board and make their decisions based on that. So thrilled with them and thrilled to be here and share with you all.
Thank you so much for sharing, and thank you again for being here. Susan, you kind of started already on my question about data, because that's really one of the things that I think all three of you have in common that I really want to talk a little bit more about is the types of data that you work with and how exactly that goes on to affect local engagement or local policy. So what types of data do you work with? And maybe, especially if you have some examples of times where data could be or did play a really key role in decision-making or evaluating local policies. No particular order. Anyone can start.
Ed, you go ahead.
I was going to leave it to the epidemiologist to start that one.
So I can speak to local. I think I'm a bit more local than the other two here. So I get the coroner data as well as talk screens. I also match each individual who died with our criminal justice records, so I can see what charges they had and how long it's been since they had a charge. I also get local hospital data, so I can see what diagnoses they had and when those occurred. And finally, one last thing I forgot, sorry. And so I pair all of this together. So, you know, for instance, I saw one of your questions, I'm going to jump ahead a little bit, an increase in minority deaths. We noticed this in April 2020. So I pulled all the 2020 data together that I had and saw that Black men by the end of the year were about 18% of our deaths, and they're 9% of our population. So at that time, we started hiring additional peer supporters who were more diverse than we had, you know, prior. Prior, it was mostly white men who were passing away. Also, this past year in 2023, I saw an increase in our deaths that involved stimulants and opioids and stimulants with no opioids, so particularly cocaine alone. And I looked at that, and it was the black men who are dying with cocaine, but of those who are dying with just cocaine or meth, they had a higher rate of heart disease, either from autopsy or from a prior diagnosis, as we would expect, right? That's kind of the mechanism of how it works when you overdose on a stimulant. So we sent out some messaging, and we're sharing that with our physicians and with our social workers. So they can reach out to folks who are using stimulants, who aren't injecting, because we've seen an increase in smoking deaths, and especially who are Black men who have heart disease. So they're doing some outreach in that way as well. So I probably have other examples, but I think those are kind of most salient for me right now. Yeah.
So that's great, Susan. It sounds like you have a very similar job as my counterpart who I work with at the state, who is the drug epidemiologist. And so she handles all of the overdoses and hospitalizations related to substance use disorder. The data that I work with, I mentioned, was the prescription drug monitoring program, which has all of the filled prescriptions in the state of Colorado for all of the controlled substances. And from that, we can gather any opioids that were filled and dispensed from that database within Colorado. So one example that we recently published on was Senate Bill 1822 here in the state of Colorado, which was sort of a way of trying to control how prescription opioids are prescribed. And so basically, if a patient is opioid naive, defined as not having had an opioid prescription within a year, of their present appointment, then they cannot be prescribed more than a 7-day supply of an opioid. In theory, this sounds okay. We worked with some university partners, the School of Medicine, and they were interested in figuring out, well, is this legislation doing anything? Is it working? Are physicians checking the PDMP? You know, it's one more step that these already busy physicians have to go through to be able to, you know, basically cater to this new legislation. And so we did an analysis, and it does turn out that it didn't really have too much of an impact. But it's because most prescribers were already doing this, because they already have some sort of continuing education, and the legislation didn't necessarily, at least from what we gathered from our analysis, didn't do much. But that's actually a good thing, because it means that physicians are very aware of this happening. And I think, you know, it's just one way, one example of how we've used the data, the PDMP data, as well as the electronic health records data from UC Health to sort of analyze a policy and sort of see, you know, well, what is really happening here, and does it work? And so, so yeah, that was really an interesting project. It was one of the first that I did when I started here at the state, and you know, I think that is a very specific policy, very specific situation, and so I think it really is dependent on how, you know, how the legislation is written. There's a lot of little things that impact its effectiveness in real life, so to speak. So, yeah.
Yeah, that's a great story. Before we keep going, I just wanted to ask a follow-up question. When you come up with that analysis, what happens after that? Like, how did the legislators respond?
So that's a good question. We just published this. The legislative session is currently happening in Colorado right now. You know, this is something that is always sort of being discussed. I will say, I don't think the policy is, you know, being done away with right now. I don't think it's on the top of the minds of a lot of at least within a lot of the bills that are happening right now. I think a lot of the focus is actually more on treatment and how we can sort of, you know, deal on that side of things. What we have also discovered, and what I think a lot of states who have well, we all have PDMPs now, so I can't even say that. Everybody has a PDMP now. But the prescription opioids are not what are causing the overdoses and the hospitalizations. You know, it's at least not not causally. Now, if they've gotten an opioid in the past, a prescription, and you know, that's another story. And maybe that has continued, you know, onward throughout their life or something like that. But we know here in Colorado that a lot of these deaths and hospitalizations are not coming from prescription opioids specifically, which is kind of the side of the data that I deal in. So, yeah.
Very cool. Thank you for sharing.
So, you know, Susan brought up this, you know, dual purpose of both having the data, which is shocking, the hard data, the rise in overdose deaths or the number of prescriptions that were peaking, you know, 5 or 6 years ago. And then also the human element, which is, you know, kind of the narrative medicine that brings it home to reality. And I think this became such a problem because it was impacting so many communities. And, you know, you had first or secondhand connections with people that either overdosed and passed away. So it became impossible to ignore. And that's when, you know, legislators tried to take, you know, some action on this. And, you know, sometimes we put money and resources into areas that are an emergency reactive. We need more of the strategic to get at these root causes, right? There's primary, secondary, and tertiary elements on how we can address the problem. And we need to invest in all of those. And it's got to be coordinated at the community and state levels, as well as the federal support for it. And Catherine kind of talks about one of the other daunting challenges we've got right now is the substance abuse, whether it's a stimulant. Xylazine has made a huge uptick in complicated, already very powerful fentanyl-laced medications that vary in the amount of fentanyl is actually in there, and the buyer has no idea how potent these things are. So some of these are unintentional. We also have to discuss potentially planned suicides by using these medications, which is a huge problem.
And Ed, the type of research that you do in the neuroscience space, do you have any examples of ever seeing data like that pop up in local or state decision making, or is it a little too fundamental that it doesn't quite get that far just yet?
Yeah, so one of the things that came out of one of the congressional task force was a blueprint for chronic pain, right? And using data to drive improvements in medical education. The famous stat was that the med students in the 4 years of medical school get significantly less training on pain management than veterinarians do. That had to change, right? So we had to somehow integrate pain education for all the prescribers and others that work with people with chronic pain, along with understanding the risks of developing substance use disorders. So that was something that I think still in action, and we're trying to continue to build better. But that was in direct response to the rise in opioid overdoses and the overprescribing of these drugs.
Very cool, very cool. So all of you also have experience with both seeing how local and state decisions are made and evaluating the policies that come from those decisions. And I'm curious, as scientists and engineers, we tend to put a lot of value in data, like what we've been discussing. But policymakers are factoring in a lot of different pieces of information when they make decisions. So what other factors do policymakers use to make these decisions that you've seen that scientists like us should be cognizant of?
I think one of the points we're making is that it's got to connect on a human being level, not just the cerebral data that can overwhelm the legislator who may not have the scientific background that we have. So we've got to be careful on how we describe things that we're very passionate about and excited about, our data and our projects, but how that really translates into the common sense and to the practical. So that's something I think all these societies are working on, is how to communicate the science to help inform policy.
That's very well said, Ed. I think it's all about how we communicate, which can be very difficult. I've taken a number of trainings on how do we communicate data, how do we do this, but until we do it, until we practice it, be on a panel like this, or talk to individuals who are curious about this data. It takes practice, and it's just all about being good at communicating clearly.
And I would also add, especially for something like substance use disorder and overdose, stigma is incredibly impactful, and legislators certainly are not immune. Ohio had a pretty high death rate in 2017. Folks were pushing for legislation for overdose fatality review for 6 years before it passed. So we didn't have any official protections until just a couple of years ago to kind of be able to share that information. And even then, our folks at the health department at the state are trying to support us, but there aren't a lot of resources. And so, imagine that over how many other policies that they, housing first, fence strips, how long did it take for Narcan to be available everywhere? I would add that as well. So even if they have the data that's pretty clear in front of them, telling the story in a way and destigmatizing these decisions in a way, not just for them, but for their constituents, I think is important to get those policies through.
And this has fortunately been fairly bipartisan in terms of seeing this as a problem and working together. And I think, in Maine, which is an interesting state, politically, one of the big drivers was the business community. Their ability to have reliable work, that didn't come to work impaired, or came to work consistently, was being compromised by this opioid crisis. So the Rotary got behind it because these were the local business owners that needed a reliable workforce. And then you could talk to legislators to say, yes, we need to put some money into this initiative, but it's going to save so much over time, particularly if we can hit the prevention or the early intervention.
Very cool. Another thing that we as ESAL really try to emphasize is that everyone should be participating in local civic engagement. And so one of the things that came to mind too about opioid epidemic is how communities that are actually affected by the opioid crisis might be not only affected by these decisions, but maybe participating and engaging in this decision making as well. So I'm curious if any of you have seen examples of how communities affected by the opioid crisis have or can get engaged in advocacy or policy development.
Well, I think it's the trainees, right? The undergraduates and graduate students getting involved. That was something I hated public speaking. I completely avoided it as an undergraduate. But then I saw the importance of it, and had mentors that spent time with me to help me communicate my science to the fellow scientists, but also the importance of conveying that information to the public, because we ultimately require them to fund the research that we do through NIH, NSF, and other federal agencies. So these types of trainings are really important. I see a few questions in the chat. One that just came up, examples of good policy related to the opioid epidemic. One of my colleagues at RVU here, Rachel Linger, I think is on the call. She worked with some med students to expand the ability to do the training for Narcan kits and then distribute the Narcan kits. And that contributed, I think, at the state level to a change in legislative action. So that was very tangible. And I gave the example of the CARE Act, which was the Comprehensive Addiction Recovery Act, introducing language that also looked at the chronic pain population, which there's some commingling. Some people with chronic pain have substance use disorders, or some substance use disorder population have chronic pain. So this is important to work together, and these led to some actual tangible changes at the state and federal levels.
Yeah, and also, the bulk fund for naloxone in Colorado has been great. We've been able to get a lot of naloxone out to various organizations that way. It's been really, it's really expanded the access, I think, and not that there's not still a lot to do and on that side of things. But one other policy that is fairly recent is doing away with there was a buprenorphine waiver that physicians used to have and in order to prescribe buprenorphine, which is a treatment for opioid use disorder, a pretty effective one. And they recently did away with that. So physicians can now prescribe buprenorphine without being waivered to prescribe this controlled substance, and in hopes of improving access to treatment for OUD. And we are at the state currently monitoring a lot of buprenorphine prescribing metrics. We're creating a dashboard that will be publicly available, so that hopefully we can sort of see if that, what I think is a positive change in policy, to see if that has actually improved or increased prescribing of buprenorphine in the state of Colorado. So exciting things to come, I think. So, yeah.
Buprenorphine is such a great example because, it's the science of a partial agonist and some interesting pharmacokinetics
Mhm.
that give an alternative to methadone or naltrexone as a therapy.
Mhm.
And then the access, right? There was they limited you how many patients you could see
Yeah.
with the training.
Yes. And there was quite a bit of extensive train. It depended on the waiver, but some, um, some of it was like, you know, quite hindering because physicians are very busy people, which I'm sure everybody knows. And so having to go through this extra step of getting basically waivered to prescribe this to their patients was quite. So this is a good. I think it's a good policy change, and hopefully we'll see something come of it. So yeah.
Be able to do it in a primary care setting rather than a methadone
Yes.
clinic,
Yeah.
drive down the stigma. And
If absolutely, yeah, that methadone, yeah, it does have to be administered within like a clinical setting, and so that definitely is for the patient can be quite an obstacle. Depending on their situation and things like that as well. It can be very difficult to get to a clinic. Maybe they're in sort of a desert, if you will, of treatment clinics as well. So it can be quite a task to even get treatment, and then you have the extra biases and stigmas with walking through that door. So, yes.
Yeah, on this subject of good opioid policies, let's be more optimistic, right? Kind of related to another question that I see in the Q&A is, for these good policies, do you have any insight into how good policies have come into place? Has it been a trial and error process, or are they doing something differently in the policy development process to end up with effective policy? And to contrast that kind of with your story, Katie, for that Colorado legislation that ended up not being particularly effective, how did that less effective legislation go through?
Well, I can speak to that. I think, it didn't come out of nowhere. There was an expert panel. There was some research that sort of was put together and sort of, they met a number of times before drafting this bill. I think it was a little maybe, and again, this is not something we studied in this study, so take it with a grain of salt. But I think it was a little bit of like it was too late to the game, and so even though their intentions were good, things were kind of already going in that direction, and sometimes bills can take a long time to pass, as many of us know. And so I think that may have been part of it. So that's, again, take it with a grain of salt, but that's sort of my what we gathered throughout the process.
Another question in the chat. Here's an interesting one. And maybe our panelists from Colorado in particular might have some insights on this. There's a ski patrol in Colorado that doesn't allow patrollers to administer Narcan. But as an individual, you are allowed to administer Narcan. Are rules like this normal, legal? And how can you get around them?
I wish I had some of my colleagues here because this is not really my area of expertise, if I'm being honest.
Yeah,
Maybe
that's a
Ed knows
really
a little
interesting
more.
situation.
yeah, I don't know if Dr. Langer can put in the chat if she knows anything about this. I'm not sure why the concern from this one ski patrol or mountain, if it's a concern about liability, but there are Good Samaritan laws that I think protect people that are responding. I can't see Narcan if there's not an opioid on board is not going to do much at all. And if there is an opioid on board, it could precipitate a withdrawal. Maybe there's a concern that they wouldn't be able to handle a severe withdrawal on the slopes. But again, you're balancing that with potentially saving that person's life. So I think that's worth a further discussion with the ski patrol, and maybe there's an association that represents all of Colorado, so we could get some more information on that and then hopefully present information on the risks and benefits, and see if they would change their approach.
I will say thanks, Ed. We do have a group of individuals with CDPHE related to the naloxone bulk fund that does training around the state, and they take requests. So it might be like, if it's an issue of them just being, like worried about it, and maybe they don't have the knowledge of how useful Narcan naloxone can be in that kind of situation, that it might be worth reaching out and saying, hey, would you mind doing like a training on it at least, and they can maybe educate at least. But just my 2 cents, you can reach out to our team at CDPHE. We're online. You can Google us. But yeah.
That's awesome that resource exists.
Yeah.
We also have another question. I really like this one. What makes the opioid epidemic different than other drug epidemics? And how do or should these differences translate to differences in policies to how to deal with it?
Yeah, so if we're just focusing on epidemics with substance use, whether it's stimulants, I've lived long enough that I've seen the ebb and flow of different substances, from bath salts and cocaine, to the opioids. We can go back a century, right? And one of our most serious opiate epidemics was in the early 1900s with patent medications. But the key difference there was that this was oral morphine, typically in a tincture, so a much slower onset. Even with heroin, which at one point was legal, it was typically not being injected. When it started to be injected in the 60s, there was an uptick in number of deaths. I think the prescription opioids introduced a whole new population to a drug that was perceived as safe because it was prescribed, and again, relatively safe when used as directed. But then you had combinations of different CNS depressants along with the opioids, switching to substitutes that were adulterating the samples that were being available in the streets, and then the pills that were tainted with fentanyl. Fentanyl is a whole new ballgame. It's so potent, it's very lipid soluble, it gets into the brain, shuts down the respiratory drive, you lose consciousness, and you're dead in a matter of minutes. So that was a whole different ballgame that contributed to this uptick. The thing that's surprising to me has been how long this has lasted, because most of the other drug cycles, kind of peak and then, the ebb and flow, whereas this latest one has been sustained for a good 10 plus years. And despite our best efforts to try to mitigate it, and I think that gets to this other question that was posted on the systems level. That's why we need to look at a systems level and try to look at what are the most effective ways to intervene with the biggest bang for the buck. And some of the root causes are really difficult to talk about when we get into the adverse childhood events and trauma and things in our community that make vulnerable populations that much more vulnerable to access and significant use. So big plug for the engineering approach. I really, maybe we got people in the audience here that see this and will help be the solution. Opioids are very seductive too. I'll add that, particularly we're talking about the age of isolation and loneliness that we're confronted. Not so dissimilar to the early 1900s when human beings thought they were going to be replaced by machines. Think about now with our phones and the internet and being connected globally with everything that's going on, the impacts of social media, and now artificial intelligence. What does it mean to be a human being? If you want to read a good book that kind of gets at some of this, is called Sapiens, and it traces the evolutionary biology of human beings. Our nervous systems were not intended to deal with 21st century life, and we're feeling overwhelmed. And the opioids are kind of that endogenous kind of medication that kind of dampens that, makes us feel whole again. So very seductive.
I think there's also this side of it where we also have to treat pain, which can be very difficult. It's finding that, I don't know, it's kind of a fine line of where do we, obviously we have to treat pain. And so, it's very difficult. I think, we're working on it. I think I'm not, but I think there's a lot of science happening right now. And how can we do this, effectively? How can we treat pain, without this really, really devastating side effect? So yeah. Thanks, Ed. I took a note of that book. I want to, sounds like an interesting read.
Put it into the chat. We're typing a response to Cynthia's question too.
Yeah, keep the questions coming in the chat, especially as we're getting close to the end of our event. We want to make sure we get to as many questions as possible. Kind of on the subject of the fact that the opioid epidemic has lasted a really long time, it has also kind of evolved over time too. So I'm curious if any of you can weigh in on how you've personally seen, or how you've seen the opioid epidemic changing over time, and maybe how policy and decision making has been changing as well. How do we approach this problem now versus 10 years ago?
Susan or Catherine, you want to start?
I asked a hard question.
There's a lot. Yeah, I think I'll just add very quickly, I mentioned that here in Colorado, we have what was called at the time in 2013, over a decade ago now, the Consortium for Prescription Drug Abuse Prevention. And before that was created, it was really, there was not a lot happening, politically, at least in this arena. And the governor sort of knew about this and had learned about this, and I don't know the background of that at all, but moral of the story is he came to who would end up being the chair of my dissertation committee, Rob Valek, at the Skaggs School of Pharmacy at the University of Colorado, to sort of set up this tag team of individuals that could go around and sort of find the biggest advocates and sort of the helpers here in the state of Colorado, so that this could sort of start happening and we could start really focusing on this. And so I think overall, what I've seen change is simply interest in it, in a positive way. And how do we help these people? How do we fix this? What can we do? So over time, we've seen a lot more engagement in that way. Not all of it good, but it is more well known now, I think, than it used to be, as it's not hiding anymore as an epidemic.
I'm really excited about the change. I mean, I've only been in this since 2017, but I'm excited in the changes we've seen in harm reduction. So during the pandemic, when folks were staying at home and they rolled out mail order Narcan, I thought that was fantastic. We're starting to see vending machines where all you do is push a button and you get your Narcan. Fence strips are not only, at least where I live, they're not criminalized as paraphernalia, but we actually get state funding to be able to purchase those. We don't have it in Ohio, but safe consumption sites, I know there's a lot of people disagree with them, but I'm excited that people are trying these things, because we know, in Dayton, it happens off the books, right? Like there's a little woman who goes around with her van and provides the service to people. So it's a need. It's something that locally people have decided that they need. and they're filling in that gap. So I mean, I think there's definitely ways to go. We had a sheriff in Ohio who was notorious for not wanting to let his people carry Narcan. Back to the ski instructor. This was a place that was also hard hit. Got caught out on John Oliver's show about it. It was like pretty high profile. We've also got some areas. I was on a call with somebody like me who syringes are still being confiscated. So if they exchange syringes with somebody and they go to the next jurisdiction, they see them coming from syringe exchange, they're going to be pulled over and have those confiscated as well. So we still have a long way to go. There's still a lot of stigma attached, but I am excited with how far we've come in the last 6-7 years.
I agree. I think, we talked about stigma, the biases people have too. And some of this is just that you don't know all the facts, right? So if we could present those, in a rational way that doesn't back people into their corners, many do come to understand, what we're doing is a mitigation strategy. It's not perfect, but it's better than not carrying Narcan or not providing fentanyl test strips. And we're open to new data guiding us to modify these processes or add in new strategies.
Wonderful. In our last couple minutes, I really like this last question that we had in the chat, and I think it's a great note to end on. They said the conversation about communicating science and data is really interesting and inspiring. Do any of you have any practical resources, advice, stories, anything to recommend to anyone who's got that science background and wants to get more involved in policy work or advocacy?
So definitely the professional societies. The one that I'm most involved with is Society for Neuroscience. We have that early, career program that really fosters the communication skills and the advocacy. We are also doing, if you have a neuroscience program on campus, training, for advocacy. More broad would be the AAAS, American Association for the Advancement of Science. They have both fellowship programs, which are fabulous. And I think they run the gamut of science and engineering, but some of the professional engineering societies probably have similar types of programs. Your university, if you're currently enrolled, may have some good programs too through their Office of Communications.
Yeah, if you're interested in epidemiology, there's the Council of State and Territorial Epidemiologists, which has a national conference, but they have a ton of free resources as well, even if you're not a member. But another thing about science communication, I am not a good vocal communicator. I love to write, and so push yourself when you have the bandwidth, take the opportunities that come to you to speak, to be part of a panel like this. I think practice is where you get that ability to communicate science clearly, and it's hard. It is hard. And so I think it's something you can always improve upon and just keep trying. Don't give up.
Great place to start is the K through 12 school systems. Work with the local
Absolutely.
school system. If you have to explain your science to a third or fourth grader, and that's where I use the bee sting, right? It's almost universal. You can appreciate something simple that we all experience and then build on that, on an age appropriate activity. And be careful with the fourth and fifth graders. They will ask you anything and everything. There's no filter. The middle school starts to get reserved and too cool to ask questions, but the K through 5 is a great place to engage. And they're looking for role models too, right? So if you're you have an interesting backstory of how you came into science or engineering, you could be a role model and inspire that person to pursue higher education and graduate work.
And I would be remiss too not to emphasize again that ESAL has a lot of great resources on our website. Again, if you're feeling inspired by everything that you've heard today, you want to get more involved in local policy or advocacy, check out our website and a lot of other great things going on there. But we will wrap up our event there. Thank you so much to our 3 panelists that were able to join us today for all the insights and advice you were able to provide. I think this was a really interesting discussion. We're so glad that we were able to host you all.